Study Chapter 20 on Diabetes mellitus. I'm going to go over important points from the chapter in this lecture. Diabetes mellitus refers to a group of disorders that are characterized by elevated blood glucose concentrations and disordered insulin metabolism. So, blood glucose stays elevated if no intervention is made. The two main types are type 1, which involves the inability to produce sufficient insulin to lower blood sugar. Remember that insulin is a hormone that's released in response to carbohydrate in the blood. The blood likes to stay within a narrow range in terms of blood glucose concentrations. So people with type 1 diabetes have an immune system that detects the pancreas as a foreign invader and attacks the cells that make insulin. In type 2 diabetes, the cells have receptors that become unresponsive to the actions of insulin. So the pancreas keeps secreting insulin, but the cells do not respond to it, and so the blood sugar stays high. My sister is a nephrologist who practices medicine, and she treats a lot of type 2 diabetes patients. A lot of them have kidney failure. With uncontrolled type 2 diabetes, you are risking cardiovascular disease and kidney disease and problems with your neurological system, including problems with your brain. Insulin resistance has been linked to inflammation in the brain and may be related to the development of Alzheimer's dementia. 12.3% of adults aged 20 and older had diabetes in 2017, and prediabetes precedes type 2 diabetes. Prediabetes is a condition in which some insulin resistance is present. 37% of adults, or over 1/3 of adults, have prediabetes, and 23% of adolescents, almost a quarter of adolescents aged 12 to 19, are also affected. Diabetes was ranked the 7th leading cause of death in 2017 and will contribute to the development of other life-threatening conditions when blood glucose is uncontrolled. So my mom did have type 2 diabetes and was able to put it in remission with control of diet and lifestyle habits. Kidney dialysis is common when blood glucose is uncontrolled. So it's very important to pay attention to blood sugar and get exercise in if you're a type 2 diabetic especially. Diabetes mellitus results in defective glucose uptake and use in the muscle cells and adipose cells. So the body's cells basically are starved of glucose. And so people with diabetes mellitus and uncontrolled blood glucose levels tend to feel hungry. Also, the impairments caused by diabetes mellitus can result in unrestrained glucose production in the liver. Hyperglycemia is characterized by marked elevation in blood glucose, and this ultimately causes damage to blood vessels, nerves, and tissues. With diabetes mellitus comes the increased urine production called polyuria. And when blood glucose levels exceed 200 milligrams per deciliter of blood, Then glucose starts to spill over into the urine, which is called glycosuria. Glucose should not spill over into the urine. Whenever glucose spills over into the urine, it can cause dehydration. Water follows glucose out of the body with urine. Glycosuria causes kidney damage and increases risk of kidney infection. Table 20-1 shows the symptoms of diabetes mellitus, which include polyuria, which is excessive urine production, having to go to the bathroom a lot, dehydration and dry mouth, polydipsia, which is excessive thirst, weight loss, polyphagia, which is excessive hunger, blurred vision, increased risk of infections, and also feeling fatigue. The body cells are essentially starved of glucose, and so this causes disordered metabolism, which can result in these symptoms. People with diabetes mellitus lose weight because the body does not process energy properly. They may get blurred vision because hyperosmolar fluids from having excess glucose in the blood, and sometimes excess insulin in the blood will damage sensitive eye tissues. Some people will lose their eyes altogether. Sugar in the urine leads to polyuria, and sugar in the urine is dehydrating, so this leads to polydipsia or excessive thirst. Sugar will carry water with it in urine. Blood glucose can be measured under fasting conditions or at random times, which is called a casual blood glucose during the day. The diagnostic criteria are given in this chapter for diagnosing diabetes mellitus. The oral glucose tolerance test is a test that can be used to diagnose diabetes. This method involves fasting for 8 to 12 hours, then administering 75 grams of glucose as usually a concentrated liquid. After a period of time, blood samples are taken, and if blood glucose is greater than 200 milligrams per deciliter, then that is diagnostic of diabetes mellitus. So after 2 hours, given a 75-gram load of glucose, if blood glucose is greater than 200 milligrams, that is diagnostic of diabetes mellitus. The gold standard for diagnosing diabetes mellitus is the HbA1c percent, also known as glycated hemoglobin, and essentially gives the percentage of red blood cells that are glycated or that have glucose attached. The measure can indicate average blood glucose for the past 8 to 12 weeks, so the past 2 to 3 months. Someone who has a 6.5% HbA1c is categorically diabetic. A 6.5% HbA1c corresponds with an average blood glucose of 140 milligrams over the past 8 to 12 weeks. This starts to be physiologically damaging. A fasting blood glucose of 126 milligrams per deciliter or higher is diagnostic of diabetes, as is a casual blood glucose, which is a non-fasted blood glucose of 200 milligrams per deciliter, and accompanied by the classic symptoms of hyperglycemia like polyphagia, polydipsia. Prediabetes occurs in people who have a fasting blood glucose of 100 to 125 milligrams per deciliter, or a casual blood glucose of between 100 and 199 milligrams per deciliter. Prediabetes is of concern because people with prediabetes are at very high risk of eventually developing type 2 diabetes, and type 2 diabetes does come with a high degree of morbidity, including fatigue, blurred vision, numbness caused from neurological damage, and other issues. The two main types of diabetes are type 1 and type 2 diabetes. There is another type called gestational diabetes that occurs during pregnancy. And diabetes mellitus can also be caused by certain medical conditions that can damage the pancreas, like cancer or radiation therapy or even liver disease. Table 20-2 outlines the general features of type 1 and type 2 diabetes mellitus. Be familiar with the differences between these two main types. 5 to 10% of the diabetic population is made up of people who have type 1 diabetes. This is caused by autoimmune destruction of the pancreatic beta cells that produce insulin and results in insulin deficiency. Insulin is required from an exogenous source, like an insulin pen or a pump. And type 1 diabetes is associated with a viral infection or other inherited factors, although its exact cause is unknown. 90 to 95% of diabetes cases are type 2 diabetes cases. It is strongly associated with obesity. Other factors that are associated with the development of type 2 diabetes include inactivity, so being sedentary is not good, also aging and inherited factors. The primary problem with type 2 diabetes is insulin resistance, where the cell's insulin receptors become resistant to the actions of insulin. In some cases, insulin secretion from the pancreas may be diminished. Sometimes the pancreatic beta cells become worn out in type 2 diabetes, but people with type 2 diabetes usually don't require the intensive insulin therapy that is recommended for type 1 diabetes. In type 1 diabetes, the pancreatic beta cells shown here are destroyed by the body's immune system. These cells produce insulin, so insulin must be supplied exogenously. Usually type 1 diabetes develops in children or teens. The classic symptoms include polyuria, polydipsia, weight loss, and weakness or fatigue. In the most prevalent type of diabetes, type 2 diabetes, cells of the organs and the muscles become insulin resistant, so they do not get enough glucose to fuel the body. A person may feel like they are starving and experience polyphagia. Hyperinsulinemia can result. This is abnormally high blood insulin. Having too high levels of insulin in the body is not healthy and can cause damage to our sensitive eye tissues. Obesity substantially increases risk for developing type 2 diabetes, with 80% of cases being associated with obesity status. In type 2 diabetes, there's been an increase in cases in children and adolescents. Unfortunately, risk factors associated with development in children and adolescents include overweight and obesity, and also a family history. It may be hard to distinguish type 1 and type 2 in children, and may make it harder to manage. In an effort to prevent diabetes, people who are overweight or obese may be advised to lose weight. A sustained weight loss of about 7% of body weight may be recommended. Dietary modifications include getting carbohydrates from healthy sources, consuming adequate whole grains and dietary fiber, limiting intake of sugar-sweetened beverages and concentrated sweets, and possibly decreasing dietary fat or calories if overweight or obese status is present. It is important to be physically active. 150 minutes of moderate physical activity per week is recommended. And annual monitoring is recommended for all at-risk individuals. This table walks you through the different effects of insulin insufficiency. Insulin is an important hormone that not only plays a role in carbohydrate metabolism, but also in the metabolism of triglycerides and in protein. This chart divides carbohydrates into blue boxes, triglycerides into orange boxes, and protein into red boxes. So when a person does not have adequate insulin, the way that it affects carbohydrate metabolism is it causes an increase in glycogen breakdown. Also, there's a decrease in glucose uptake by cells. Both of these result in hyperglycemia. Having excess blood glucose results in glucose in the urine. Having glucose in the urine causes excess urination or polyuria, and dehydration. Dehydration causes excessive thirst, also known as polydipsia. Polyuria contributes to increases in blood osmolarity, and increases in blood osmolarity are associated with nervous system malfunctions and nervous system damage. In terms of triglyceride metabolism, when insulin is insufficient, there is an increase in triglyceride breakdown in the adipose tissues. This leads to an increase in the amount of fatty acids in the bloodstream. When fatty acids are increased in the bloodstream, there's an increase in the fatty acid oxidation in the liver. So fatty acids are metabolized in the liver at an increased rate. This results in the production of ketone bodies, which leads to a condition called ketoacidosis, in which the body's fluid sits out of pH range. So pH homeostasis is disrupted and the body's fluids become too acidic. There is decreased triglyceride synthesis in adipose tissue, which leads to weight loss. The increase in blood fatty acids from an increase in triglyceride breakdown leads to an increase in the number of VLDL, which are very low density lipoproteins. This contributes to excess triglycerides, also known as hypertriglyceridemia, excess triglycerides in the blood. Insulin insufficiency contributes to protein disordered metabolism, so there's an increase in protein breakdown and a decrease in protein synthesis. This leads to muscle wasting and weight loss. An increase in protein breakdown causes an increased number of blood amino acids. This will result in an increase in glucose production in the liver, and this will aggravate hyperglycemia. Many of the acute complications of diabetes mellitus are discussed in this chapter. Diabetic ketoacidosis is often associated with type 1 diabetes and is caused by a severe lack of insulin. Severe ketosis occurs, which is characterized by abnormally high levels of ketone bodies and acidosis, in which the body's fluids have a pH of less than 7.3. Hyperglycemia is present, and blood glucose levels are usually above 250 milligrams per deciliter, and symptoms of diabetic ketoacidosis may include acetone breath or fruity breath, marked fatigue, lethargy, nausea, and vomiting. Depending on the severity of diabetic ketoacidosis and an individual, a person's mental state will range from alert to diabetic coma. Treatments for diabetic ketoacidosis include insulin therapy, also intravenous fluid and electrolyte replacement, and in some cases bicarbonate therapy to increase the pH of body fluids. Hyperosmolar hyperglycemic syndrome may occur in type 2 diabetes. This may include severe hyperglycemia and dehydration that can develop in the absence of significant ketosis. Symptoms of HHS syndrome include neurological abnormalities, which can include confusion, speech impairment, and also seizures. Treatment includes intravenous fluid and electrolyte replacement and insulin therapy. Hypoglycemia may result as a result of inappropriate management of diabetes. This is often caused by excessive dosages of insulin or excessive dosages of anti-diabetic drugs. Prolonged exercise may be a cause, as well as skipped or delayed meals. And this is a problem, especially in type 1 diabetes. Some of the symptoms may include sweating, heart palpitations, shakiness, hunger, and weakness. Treatment of hypoglycemia includes administration of glucose in the form of tablets, juice, or candy. Traditionally, it's been the administration of approximately 15 grams of glucose and rechecking blood sugar in 15 minutes. Glucose is able to combine with protein non-enzymatically and easily, and with long-term uncontrolled blood glucose levels, advanced glycation end products can be the result. These molecules alter protein structures and can end up damaging our tissues. High blood glucose is associated with the accumulation of a molecule sorbitol, which increases oxidative stress. Oxidative stress is associated with increased risk of chronic disease, and sorbitol damages cells or causes cellular injury. Macrovascular complications damage large blood vessels, and having elevated blood glucose accelerates the development of atherosclerosis in the arteries of the heart, brain, and limbs. In peripheral vascular disease, damage to the blood vessels can result in claudication, which is pain with walking, foot ulcers. The nerve damage that is associated with elevated blood glucose may make it difficult for someone with these problems to recognize a wound. This may lead to an infection. The infection may lead to gangrene. Gangrene may lead to an amputation. I did have a lot of patients at the LTAC who had type 2 diabetes, and a lot of them were frequent flyers, and some of them, would just didn't make it, and I would show up to work, and they would tell me that they passed. So it's important to take this seriously. Microvascular complications damage small blood vessels. Blood vessels of the eyes can be affected. Diabetic retinopathy can result, which is characterized by weakened retinal capillaries that leak fluid, lipids, or blood, causing local edema or hemorrhaging. Diabetic nephropathy affects the kidneys and results in decreased urine production with an accumulation of nitrogenous waste. It results due to microvascular complications associated with having elevated blood glucose levels. Diabetic nephropathy can lead to kidney failure, kidney dialysis, and even the need for a kidney transplant. Diabetic neuropathy affects the nerves. The extent to which it affects the nerves is determined by the severity and duration of hyperglycemia. Symptoms include deep pain or burning in the legs and feet, weakness of the arms and legs, including numbness and tingling, and occurs in about 15% of diabetes cases and can lead to amputation. Diabetes mellitus treatment requires lifelong therapy, which may include balancing meals, medications, and exercise is always important. With insulin, frequent adjustments may be necessary to establish good glycemic control. And whether it's type 1 or type 2 diabetes, checking blood sugar is important. To prevent or reduce the risk of acute and chronic complications. This chart compares conventional and intensive therapies for type 1 diabetes. With intensive therapy, blood glucose is monitored more frequently. With insulin therapy, dosages of insulin are adjusted more frequently. And an advantage of intensive therapy is the delayed progression of retinopathy, nephropathy, and neuropathy. It does increase the risk of hypoglycemia, however. Weight gain may also result, and there is also an increased risk of becoming overweight. Self-monitoring of blood glucose is very important. And with long-term glycemic control, the HbA1c percent test is a valuable tool. It reflects glycemic control because it is reflective of the amount of glucose in the bloodstream that is available and attaches to red blood cells. The longer and higher blood glucose levels are, the more glucose is available to attach to red blood cells. Monitoring for long-term complications is important in evaluating the effectiveness of diabetes treatment. Some of the things that can be evaluated include blood pressure, lipids, checks for urinary protein, and also ketone testing. The nutrition therapy aimed at attaining glycemic control is associated with a slowing of the progression of diabetic complications. The macronutrient intakes established by the DRI committee can be used as a guide for carbohydrate, fat, and protein intake. Metabolic factors may influence the percentage of calorie distribution from carbohydrate, protein, and fat. It's important to maintain consistent day-to-day carbohydrate intake, and if on insulin, to match insulin to carbohydrate intake. But you don't want to consume excess carbohydrate and then inject excess insulin. Excess insulin is associated with its own set of negative physiological effects. So consistent day-to-day carbohydrate intake is important. The number of grams of carbohydrate that an individual needs will be individualized and calculated and distributed throughout the day. The recommended sources, however, are going to be from healthy carbohydrate sources like vegetables, fruits, whole grains, legumes, and milk or milk substitutes that are fat-free or low in fat. It is recommended that people with diabetes and also the general population minimize added sugars in the diet and concentrated sweets like from honey. Using fructose as an added sweetener is not advised. The FDA has approved artificial sweeteners in certain amounts, and that's usually based on kilograms of body weight. Fiber recommendations are similar to those for the general public. It is important to consume adequate amounts of omega-3s in the diet from fatty fish or plants. Further, people with diabetes are recommended to limit saturated fat to less than 10% of total kilocalories. So if someone is following a 2,000 kilocalorie per day eating pattern, then that means less than 20 grams of saturated fat per day, following these recommendations in this chapter. Trans fat should be minimized. Partially hydrogenated oils are a source of trans fat and are not necessarily listed out as a number on the nutrition panel. So read the ingredient labels and make sure that you are excluding partially hydrogenated oils from your diet. Protein recommendations are similar to the general population. For people who have chronic kidney disease, consuming excess amounts of protein does harm the kidneys. The micronutrient recommendations are the same as that for the general populations, and supplements of vitamins or minerals are not generally recommended for managing diabetes. Some drink equivalents are shown here. It is recommended that women consume no more than 1 drink equivalent per day, and men consume no more than 2 drink equivalents per day. The American Diabetes Association has suggested that type 2 diabetes can be put into long-term remission. Monitoring of blood glucose is still necessary, and it's important to get checkups for HbA1c percents. A patient must have achieved glycemic control. A moderate amount of weight loss can benefit people who have type 2 diabetes. Your textbook does mention the honeymoon period as a brief period of remission that's usually present, if present, when type 1 diabetes is first diagnosed. Type 1 diabetes does not go into a long-term remission and requires lifelong insulin therapy. Dietitians are trained to counsel patients on techniques to manage eating with type 1 diabetes and other diseases. Carbohydrate counting is one such method for managing meals and involves separating carbohydrate foods into 15-gram carbohydrate increments. This is a sample carbohydrate distribution pattern for a 2,000 kilocalorie diet. This person is allowed 17 carbohydrate portions, which is equivalent to 255 grams of carbohydrate. This is spaced throughout the day and should come from healthy carbohydrate sources. Protein should also be spaced throughout the day and ideally paired with carbohydrate and healthy fat. The distribution shown here shows 60 grams of carbohydrate at breakfast, which translates to 4 carbohydrate portions. Carbohydrate portions are also referred to as carbohydrate exchanges. Every carbohydrate portion contains 15 grams of carbohydrate. So someone who is allowed 60 grams of carbohydrate at breakfast can have 4 carbohydrate portions, with each portion being usually standardized. So half a cup of 100% fruit juice is 1 carbohydrate portion and contains approximately 15 grams of carbohydrate. 1 slice of bread contains approximately 15 grams of carbohydrate and counts as 1 carbohydrate portion. And take a look at Appendix C in your textbook for food list for diabetes. You can see different specified portions of food that contain 15 grams of carbohydrate. Food lists and carbohydrate counting allow flexibility for people with diabetes who require evenly spaced carbohydrates, or a way to match carbohydrates with insulin therapy. People with type 1 diabetes require insulin. People with type 2 diabetes usually do not require insulin. However, there are some people with type 2 diabetes whose pancreatic beta cells have become fatigued and produce less insulin than is required. Insulin treatment should reproduce the natural pattern of insulin secretion as closely as possible, and there are a number of different types of insulin therapies that can be prescribed by an endocrinologist. The various insulin preparations are outlined in Table 20-6. There are different durations and peaks among the different forms of insulin. They include rapid-acting, short-acting, intermediate-acting, and long-acting. An endocrinologist will determine the best combination for patients who require insulin. Insulin can be delivered by subcutaneous injection using a syringe, a pen, or an insulin pump. The use of oral delivery is prohibited because insulin is a protein hormone that would be destroyed upon digestion. in the gastrointestinal tract. Someone who requires insulin should be under the care of a specialist called an endocrinologist that manages hormones. The different durations of actions of different types of insulin are shown here. They have different peaks and different durations. In type 1 diabetes, insulin is required. However, there may be a temporary remission at the beginning of disease onset in which there is reduced need for insulin, where the beta cells are still producing insulin, or they may overproduce insulin. This improvement in pancreatic beta cell function is temporary. It may last for days, weeks, or months. With type 1 diabetes, it requires usually intensive therapy to gain glycemic control. People with type 2 diabetes do not require such intensive therapy and usually do 1 to 2 daily injections. Up to 30% of patients with type 2 diabetes may benefit from some insulin therapy. There are different regimens, and insulin can be used alone or in combination with oral anti-diabetic drugs that are discussed in this chapter. The use of insulin comes with risk of hypoglycemia. It is the most common complication of insulin treatment. It can be corrected by immediate intake of glucose or glucose-containing food. However, if your blood sugar drops too low, you can die. Insulin therapy may result in weight gain in some people, particularly with intensive insulin therapy. It doesn't always have to be so, though. Table 20-7 lists anti-diabetic drugs for type 2 diabetes treatment. These include oral medications and injectable drugs other than insulin. Some act to delay carbohydrate digestion and absorption. Some act on the pancreas, and some may have an unknown mode of action. So it is important to consider side effects of anti-diabetic drugs when diet and lifestyle habit changes are an option. Physical activity plays a role in diabetes management. With type 1 diabetes, it's important to consume adequate carbohydrate and not overdo exercise. With type 2 diabetes, physical activity can help improve glycemic control considerably. 150 minutes of moderate intensity activity is recommended over at least 3 days a week. Both aerobic and resistance exercise can improve insulin sensitivity, so how sensitive the cell's insulin receptors are to the actions of insulin. For people who have type 1 diabetes, it's important to check blood glucose before and after exercise. And it's important for people to avoid vigorous activity during ketosis when the body is acidic in overproducing ketones. Sick day management for people with diabetes is discussed. For people with type 1 diabetes who require insulin, it's important to measure blood glucose and ketone levels several times daily. Continue drugs or insulin as prescribed, and adjustments to insulin may be needed if the diet is altered or if persistent hyperglycemia is present. Stress tends to cause increases in blood sugar. Maintaining prescribed carbohydrate intakes is important, and it's important to consume liquids to prevent dehydration. There are hormonal changes that occur during pregnancy that can increase risk for a woman developing gestational diabetes. Gestational diabetes occurs when maternal insulin levels are insufficient to meet needs. This results in an increase in maternal glucose, amino acids, and lipids. This also increases the amount of fetal insulin present and can result in a baby having a large body called macrosomia. 4 to 14% of non-diabetic U.S. women develop gestational diabetes. In pregnancy, uncontrolled diabetes is linked with an increased risk of having a miscarriage, birth defects, fetal deaths, and also newborns are more likely to suffer from respiratory distress. Women with diabetes also often deliver babies with macrosomia, which is abnormally large bodies. This can make for delivery that is more difficult and result in birth trauma. Women with gestational diabetes have a greater risk of developing type 2 diabetes later in life. So it's very important to develop or control blood glucose levels during pregnancy if you have gestational diabetes. For women who have diabetes, it's important to attain glycemic control at conception, and especially during the first trimester of pregnancy. This substantially reduces risk of birth defects and spontaneous abortion. Women with type 1 diabetes require intensive insulin therapy during pregnancy, and it makes it all the more important to be mindful of carbohydrate intake in the diet. Women with type 2 diabetes are usually switched to insulin therapy during pregnancy. To avoid hypo and hyperglycemia during pregnancy, it's important to balance carbohydrate intake with insulin treatment and with physical activity. There are some risk factors for gestational diabetes in your textbook. They include a family history, certain ethnicities, obesity, a history of giving birth to an infant weighing over 9 pounds. For overweight women who have gestational diabetes, a moderate calorie reduction, about 30% less calories than needed, may improve glycemic control, and limiting carbohydrate intake to 40 to 45% of calories may improve postprandial blood glucose, or postprandial means after you eat. Restricting breakfast carbohydrates to 30 grams may also help with glycemic control. Spacing carbohydrates throughout the day is important, and consuming balanced meals and snacks that contain protein and healthy fat at most meals is recommended. Regular aerobic activity can improve glycemic control, and if glycemic control cannot be improved, With diet and exercise, insulin or an anti-diabetic drug may be necessary. Metabolic syndrome is featured in the nutrition and practice section in this chapter. When a person has 3 or more of the abnormalities listed in table NP 20-1, then it is diagnostic of metabolic syndrome, which is strongly associated with cardiovascular disease development. Hyperglycemia may be present, which is defined as having a fasting plasma glucose of greater than or equal to 100 milligrams per deciliter. Abdominal obesity, which is greater than 40-inch waist circumference in men or greater than 35-inch waist circumference in women. Hypertriglyceridemia is defined as having a very low density lipoprotein level of greater than or equal to 150, having a reduced high density lipoprotein cholesterol level is not healthy. If you're a man, less than 40 milligrams per deciliter is not a good indicator, and if your HDL is less than 50 and you're a woman, it is not a good indicator. Having hypertension, which is defined here as having a blood pressure greater than or equal to 130/85. So having 3 or more of the features listed here is diagnostic of the metabolic syndrome. Treatment for metabolic syndrome may include weight loss, dietary modifications, physical activity, and medications. Let me know if you have any questions about Chapter 20 or Diabetes mellitus.